Methods of management trauma. Bones need to be held in the correct position well for two reasons. First, so that they join in the correct position, and second, prevent pain at the fracture site. There are several ways to hold bones while they heal. Traction, splints, slings and casts, cast bracing, external fixation and internal fixation. Traction. Pulling on a broken limb draws the bones into the line just as the strength of the bed straightens when it's pulled at each end. Muscular contraction will shorten any limb unless there is a bone to hold its ends apart, and the traction must therefore be strong enough to overcome the muscle power, but not so strong that it holds the ends apart. Traction can be applied to the limb in a variety of ways. Skeletal traction. Traction is applied to pins passed through the bone. Although metal pins passing straight through a limb may look unkind, they are more comfortable than skin traction and allow substantial loads to be applied accurately to the bone itself. The common sites for the insertion of skeletal pins are the upper end of the tibia and the calcaneum, but traction can also be applied to the skull, pelvis, and many other sites. Two types of pin are in common use. Stamen pin. A stamen pin has a trocar point and smooth sides. Although easy to insert, it can slip sideways after being in position for a week or more, which is both uncomfortable and unhygienic. Threaded pins, such as a Denon pin, have threads which grip the bone and prevent lateral slippage. Although slightly harder to insert, they are better in the long term. Skeletal traction is easy to set up and manage provided attention is paid to the following points. The pin should be drilled through the bone with a hand drill or T-handle. If the pin is inserted using local anesthesia, the skin and periosteum must be carefully infiltrated at the points of entry and exit. Never try to hammer the pin through the bone. This does not work and breaks the bone. Keep the point of entry clean to avoid infection of the pin track, but do not wind a bandage around the pin like a cleat. This causes skin necrosis. Check whether the pin is threaded or smooth before removing it. Smooth pins can be removed with a straight pull, but a threaded pin must be unscrewed. If the pin area is painful and the bone is tense to a percussion, suspect a pin track infection. Skin traction. Skin traction is applied by means of adhesive strapping stuck directly onto the skin and has many practical problems. The skin beneath the strapping becomes sweaty and rashes are common. The weight is applied to the bone indirectly with the soft tissues, and this can be disrupted if too much weight is applied. 12 pounds 5 kilograms is the usual upper limit. For this reason, skin traction is really only suitable for children and as temporary measure in adults until a definitive treatment is instituted. The mechanism of traction. The mechanism of traction is straightforward. Every force has an equivalent opposite force. Traction is no exception. The opposite force to traction can be applied in three ways described below. Fixed traction with a splint. In the simplest form of fixed traction, the limb is rested on a splint such as the Thomas splint, originally devised by Hugh Owen Thomas for applying fixed traction to the lower limb, and still widely used. The lower end of the splint has a V-shape to hold traction cord applied to the patient's limb either by skin traction or as a first end measure by tying the patient's boot to splint. The limb is then staged with a Spanish windlass, nowadays usually made of two wooden tongue depressors, and the counter pressure taken by a padded leather ring at the upper end of and the splint. The Thomas splint is ideal for transported patients because it's self-contained, does not need pulleys or weights. Fixed traction using gravity. The fundamental principle of this type of traction is to string the patient up by the injured limb and leave them hanging until the bone has joined. Gallows traction for children under the age of 3 is fractured femur is a good example of this. The children tolerate the position surprisingly well for the 2-3 weeks necessary for the fracture to end at this age. Gravity can also be applied to the limb by fixing the patient's leg to the foot of the bed with the wrist then raised so that the patient slides down towards the pillow. A similar principle is used in a hanging cast for fractures of the humerus, in which case is applied to a forearm and suspended by a collar and cuff so that the combined weight of the arm and cast pull the humerus into line. The arm must hang. A sling supported the elbow prevents the traction reaching the fracture site. Sliding traction. Suspending the patient, tying the feet to the end of the bed restricts their mobility and makes nursing difficult. This can be overcome by weights and pulleys, but the system is complicated and needs regular adjustment. At its simplest, sliding traction is little different from fixed traction, except that the patient can move freely in his bed, but more complex arrangements are possible. Hamilton-Russell traction uses a single cord to apply a horizontal force that is twice the vertical force because the cord on its horizontal run runs through the free pulley system, which gives it a velocity ratio of 2. This means that a 2-pound weight will exert a 2-pound upwards pull, but a 4-pound longitudinal pull. Balanced traction. It is uncomfortable to leave a broken limb lying on a bed so that the fragments rub against each other whenever the patient turns over. Greater comfort can be achieved by resting the limb on a splint which is suspended so that the limb is in effect in a gravity-free field. In the most complicated arrangements, the down by resting the leg on a Thomas splint with weight and pulley attached to each corner. If the weights are correctly adjusted, the patients can be lifted almost with a fingertip, which makes nursing easier and avoids pressure sores. None of these weights act on the fracture, which must be controlled by a longitudinal force. Although there are many advantages in complex system of balanced traction, they are difficult to maintain and simple mass system is often better. Splints, slings, and casts. Any device which holds a fracture steady is a splint, and those which set hard around the limb are casts. A cast will hold a limb straight and still, but cannot hold it out to length. Casts therefore are unsuitable for fractures in which the limb is shortened. To maintain the alignment of a bone, the plaster is not just wrapped around the leg and allowed to set. Pressure must be applied to the cast while it sets so that the bones are held accurately by 3 pounds pressure. In most fractures, it is necessary to immobilize the joint above and the joint below the fracture. Splints do not provide rigid fixation. If applied immediately after the fracture, they will become loose as the swelling of trauma subsides and muscle wastes. The position of the fracture must be checked regularly and the position reviewed. If the fracture slips, there are several options. The position may be accepted, the fracture may be manipulated again, conservative treatment may have to be abandoned. All casting benches consist of solid element covering a fibrous material. The solid part gives rigidity and the flexible part prevents it cracking. Reinforced concrete contains steel rods for similar reasons. The original casting material was developed by the ancient Egyptians who are said to have treated fracture by resting the injured limb in boxes containing nail mud and straw which set hard and was broken away when the fracture had ended. An Arab surgeon was the first to describe the use of plaster to treat fractures, but it was not until the early part of the century that plaster was widely used in Europe. Plaster of Paris. The best known casting material is plaster of Paris, a high quality gypsum which originally came from Montmartre. Plaster of Paris benches consist of a tough open wave fabric coated with a hemi-hydrated calcium sulfate powder. Bulk muslin or crinoline were originally used as a fabric. When dipped in water, the plaster becomes too hard and crystalline hydrated calcium sulfate. The chemical reaction result is exothermic and the plaster therefore becomes warm as it sets. Plaster of Paris is light compared to the soft pearl so that the limb can be brief, easily to remove and has stood to the test of the time. Its greatest disadvantages are that it disintegrates when wet and the 2-3 days are needed for it to harden enough to take the patient's weight. Modern materials, including resins and fiberglass have not yet displaced plaster of Paris. Some are impermeable and the skin becomes macerated beneath them, and others include self-curing resins which cause skin sensitivity. A few are like pearls, waterproof and non-allergenic, but so hard that they need a diamond edges power so to remove them. Applying a pastel correctly takes much practice, but the following points are particularly important. First, padding. Apply a light padding of soft wool or cotton over bony areas to avoid pressure sores, preferably over a thin layer of stockinette so that the padding will not roll up inside the cast and cause uncomfortable ridges. Second, water temperature. The hotter the water, the faster the plaster sets. Cold water gives more time to apply the casts and recommended for beginners. Third, dipping. When dipping a plaster bandage, hold it lightly so that water can penetrate to its center. Hold it under the water until the bubbles stop, and then drain it until the drips stop. Don't wearing it out like disclosed. 4. Application. Lay the bandage carefully over the limb and do not pull it tight. 5. If a joint has to be held flexed to 90 degrees, flex it 10 degrees more, apply the plaster, and then part the limb in the correct position. This avoids hard wrinkles in the plaster which can cause pressure sores at the flexure crease. 6. Splitting the cast. If the plaster is applied soon after injury or it or at operation, split the cast and padding down to skin so flat it can be sprayed or removed quickly. Once the plaster is applied and set, check the following. Edges. Check that the edges are not too sharp and don't press on the skin. If they do bend the edges, but do not cut the edge off because this loosens the plaster and makes the problem worse. Circulation. Check that the peripheral circulation is good, that toes and fingers will extend fully and have normal sensibility, color and circulation. If they don't, the plaster means splitting or removing. Tell the patient that if the limb is painful, numb, cold or discolored, they should seek help at once. Removing a plaster also needs care. Saws. If an isolating saw is used to cut the plaster, it must only be pressed up and down, not dragged along the length of the cast. The saw blade can cause a nasty scratch if dragged along the skin, and a blunt blade can burn. Before using the saw, test the blade on the skin if you own forearm. This will reassure the patient and remind you that the instrument is potentially dangerous. Shears. If plaster shears are used, particularly on an unconscious patient, be certain that the shears cut plaster only and don't bruise skin. It is distressingly easy to break the skin, especially in older patients. Warn the patient that the limb will be stiff and that much hard work will be needed to restore normal function. If this is not done, the patient will be disappointed and may lose confidence. Slings. Slings are used to support an injured arm or shoulder. There are four main types. Broad arm sling made out of a triangular bandage. These slings support the forearm and elbow and takes the weight of the upper arm. Collar and cuff. A collar and cuff does not support the elbow and allows the upper arm to hang free. This link is used for fractures of the femurs and other injuries in which the weight of the limb will maintain alignment. High sling. A high sling holds the hand well up and is useful for hand injuries, but the position is uncomfortable. If there is a soft tissue swelling at the elbow, although nerve damage can occur. Sling and thread. Sling and thread body bandage is worn under the clothes. This arrangement prevents any movement of the arm and useful after shoulder operations. Cast braces are applied very closely to the limb with the hinges to allow joint movement, important for articular cartilage nutrition. With cast brace, patients are able to bear full weight upon the injury limbs much sooner than with conventional splints, but they are difficult to apply and require special attention to detail. For the femur, for example, the cast should fit snugly around the upper part of the thigh so that the fascial sheath of the muscle can act as a hydraulic chamber to maintain length, and the hinges must be applied accurately or they will not function. External fixation. Fractures which cannot be held reduced on traction or in a cast need to be fixed either internally or externally. Internal fixation can be used if the wound is contaminated or if the skin is lost because of the risk of infection. The external fixation must be used instead. External fixator is nothing more than a scaffold or gantry attached to threaded pins set in the bone fragments. At its simplest, external fixation can be applied by means of a bar secured to pins with the same acrylic cement used to fix joint prostheses, but many systems incorporating ingenious universal joints are now in general use. An older technique of external fixation was to incorporate pins into the patient's plaster, but the cast did not grip them tightly enough to hold the fragments in position. External fixation is used not only for long bone fractures but also for maxillofacial fractures and spinal surgery where hollow pelvic section supports the spine with bars linking the skull and pelvis. External fixation has two great advantages. It can be used in patients with skin loss and infection. The position of the fragments can be easily adjusted. Some types of external fixator provide such rigid fixation that they shield the fracture from stress and actually delay union. Other designs allow a little movement to avoid this problem. Internal fixation. Bone fragments can be reassembled and held in a perfect position with screws, plates, wires, and nails. Although perfect integral reduction is important, it is not so important that every fracture must be internally fixed. It is better to have a credible limb than a perfect radiograph. The main indication for internal fixation are: first, fractures cannot be controlled in another way. Patients with fractures of more than one bone, fractures in which the blood supply to the limb is burst and the vessels must be protected. The disadvantages of internal fixation are the risk of infection at the time of operation, the additional trauma of operation, a wide exposure is needed to apply screws and plates, and this must devitalize some of the bone and the soft tissue. There is no virtue in replacing healthy fracture in a most perfect position with a bone that is undoubtedly perfect but dead. The following internal fixation devices are in common use. Screws. Bone screws are different from wood screws and metal screws. Wood is a fibrous veritable material and wood screw is designed to cut its own thread as it is driven into a prepared hole. Because wood is fibrous and slightly soft, the tapered chunk of the screw does not split the wood unless the original hole is too small. A metal screw, on the other hand, cannot find its own way through metal and must have its thread cut with a tape before it is inserted. Bone is different from wood and metal, and different types of screw are used. Two types of bone screws are commonly used, but others are available for special application. Cortical screws. A hole is first drilled at a chosen angle and tapped to take the screw. Self-tapping screws are also available but cut a less precise thread. Casserole screws, which have a fried thread, almost like a corkscrew, and grip soft casserole bone. Screws are used to compress plates against bone or bone fragments against each other. When used to hold bone fragments together, the screw must grip only the fragment near the tip of the screw. If the thread engages both fragments, it will hold them apart instead of pressing them together. To avoid this problem and achieve compression, the fragment near the head of the screw can be over-drilled so that the screw does not lock grip to the bone, or a lock screw can be used. Plates. Plates are used not only to hold bones in correct position, but to compress the two bone ends together. The plates should always be applied on the tangent side of the fracture with compression whenever possible. The tangent side of a fracture, the one on which the deformity passes soft tissue under tension. Compression can be applied in three ways. The plate is fixed first to one fragment, then the other, and the two ends bolt together with a small screw clamp. The plate is then fixed to the second fragment and the clamp removed. The two screws furthest from the fracture can be applied, leaving a slight gap between the plate and the bone. As the remaining screws are inserted, the gap is obliterated and pressure applied to the fracture site. Third, dynamic compression plate (DCPs) can be used. DCPs are designed so that the shoulder of the screw presses against the edge of the screw hole and applies pressures at the fracture and the fracture site. The disadvantages of plate are as follows. Wet exposure is needed to give access to the fracture. The plate may be so large that it's difficult to close the skin over it. The plate is so rigid that it causes a stress riser at each end, where fractures can occur. This can be reduced but not eliminated by putting the end screw through one cortex only so that it does not grip to the bone so firmly. The rigidity of the plates leads to disuse osteoporosis of the underlying bone. Because of points 3 and 4, plates should always be removed from the femur and tibia, even though this means another operation risk of fracture through one of the screw holes immediately after the plate has been removed. Intermedullary nails. Intermedullary nails are used for fracture at the middle of long bones and are excellent for maintaining length and alignment. The nails are incomplete cylinders which grip the sides of the medullary cavity. Intermedullary nails have some disadvantage because the medullary cavity varies in width and is never at the center of the bone. The shaft must be rimmed carefully to produce a precisely machined channel to take the nail. If such a channel cannot be created, the nail will not hold the fracture firmly. Although nails hold length and alignment, they are less effective for controlling rotation. There is a risk of devitalizing the bone by exposing the bone and rimming the medullary cavity of each fragment. Because of this, it's preferable to insert intermedullary nails by a closed technique using an image intensifier. Locking nails. It is possible to insert an intermedullary nail and fix the fragments of the bone to the nail itself. These nails are extremely useful for the segmental fractures of the long bones, especially the femur, because they maintain length and rotation as well as alignment. In some ways, they serve the same purpose as external fixator, except that they are beneath skin. The main disadvantage of locking nails is the difficulty in inserting them and the length of the operation required. Wires. Wires can be used to fix fracture in two ways. First, tangent band wiring, in which the wire is applied as a loop to the outer side of the fracture so that it comes under tension when the joint is flexed. The technique is particularly useful for fractures of the patella and olecranon. Second, circus wiring, useful in the spiral fracture with minimal displacement. The technique requires very little surgical exposure. Wires have the following disadvantages. Tangent band wiring can slip, the wires may break, the wire is palpable under the skin and sometimes has to be removed. Circular wiring does not provide easy fixation and the wire can strangle the bone, causing the tips of the fragment to break off, or even the whole bone to break transversely. Nail plates. Some fractures, particularly the very common trochanteric fracture of the femur, can be treated with a nail and plate. The nail grips the proximal fragment and the plate is screwed firmly to the femoral shaft. Selecting treatment. Selecting the right way to treat a fracture is not always easy. Some are wildly unstable and always need to be internally fixed, but some do so well with conservative management that operation need to be considered. A selection of treatment must take into account the state of the skin, the age of the patient, the degree of bone displacement, and the likelihood of the patient cooperating with treatment. What if fractures need special foot? Fractures involves both bones of one limb. It's difficult to apply traction to both bones in the same limb, and it's usually better to fix both bones. If this is not possible, fix one bone and treat the other conservatively. Fractures of the same bone in both limbs. These are more easily managed if at least one fracture is fixed internally so that it can be left free of traction. Segmental fractures, in which one bone is broken in more than one place. They are most impossible to control unless both fractures are fixed. When this fracture are considered together with the state of the skin, associated soft tissue injury, and the fitness of the patient. The management of fractures is not as straightforward and mechanical as some people think. Complication of treatment. Complication of traction. Over distraction, loss of position, pressure, psoas, pin-tack infection. Traction is not an easy option. If patients are put on traction and left unattended until the fracture has unted, problems are bound to occur. Setting up uh, traction requires great attention to detail, and to maintain it requires even more. In orthopedic hospitals with many patients on traction, there is usually a traction sister responsible for checking all the traction in the hospital daily and ensuring that complications are avoided. Overdistraction. Pulling too hard on a fracture causes circulatory embarrassment, stretches and damages nerves and holds the fragments apart so that they do not join. The amount of weight applied to a fracture must be carefully adjusted, particularly in the first 10 days, so that the bones are out to length but not over-distracted. Loss of position. The position of the bones must be carefully checked to be sure that they have not slipped or overlapped. The fracture should be examined radiologically with portable X-rays at the patient's bedside at least twice a week for the first 2 weeks. Pressure sores. The skin is very vulnerable to pressure sores in the usual pressure areas and under the splint with a fire ring or coarse press the patient. This needs careful observation. Pin-tack infection. Although the pins of skeletal traction and external fixation are usually trouble-free, infection can occur where the pin passes through the skin and progresses along the pin. If this occurs, the skin is painful around the pin and the bone will be tender to gentle percussion. The infection should be treated by cleaning the skin carefully and by giving antibiotics. This treatment should be continued until the pin is removed. Complication of casts. Casts are rigid boxes and lips can be expanded inside them. Swelling in a cast causes a similar problem to a compartment syndrome. The blood supply to the limb is impaired, sometimes enough to cause gangrene, needing amputation, but more often the muscle bellies become ischemic and heal by fibrosis, which causes a disabling contracture. Equinus deformities of the ankle, following fracture of the tibia and fibula, and flexion deformities of the wrist and fractures of the forearm are the commonest examples. To avoid this complication, every patient with a cast is reviewed 24 hours after it's applied and checked to make certain that none of the following signs are present: swelling of the digits, loss of extension of the fingers or toes, diminished sensibility, cold or dusky skin. If any of these signs is present or there is any doubt about the circulation, the cast should be split down to the skin or removed completely. It is not enough to split the outer layer of the cast. Bandages and dressing can constrict a limb, particularly if blood has made them hard. Special vigilance is needed if there is bleeding under the cast. To tell if bleeding is continued, draw on the edge of the stain with a felt tip pen and mark the line with the date and time. If the blood stain is expanding, the plaster should be removed. Pressure sores. A tight spot inside a cast can cause a pressure sore, and then any doubtful area should be inspected by windowing the plaster or removing it. If a plaster is windowed, the window must be replaced and benched into position so that the underlying soft tissue does not swell and protrude through the dial hole in the plaster. Infection. It's hard to be certain if the infection under a plaster, but smell is a good guide. Don't feel embarrassment to sniff a plaster, especially one that is stained. Patients should be discouraged from poking rollers and straighten out wire coat hangers down the case to scratch the skin. Joint stiffness. The purpose of cast is to embellish the fracture, but the neighboring joints are also embellished. Some patients feel they must hold the rest of the limb stiff as well, and this can lead to permanent loss of motion. Patients must be urged to move even joint that is not embellished as vigorously as possible, particularly the hand and fingers. Patients with close fracture, for example, have a tendency to leave the arm resting unused in a sling until the cast is removed, by which time there will be severe stiffness of the fingers, elbow and shoulder requiring many months of physiotherapy to restore movement. Complications of internal fixation. Infection of open fractures has already been mentioned. Infections of closed fractures treated by internal fixation is even more serious because it's the direct result of treatment and probably introduced at operation. Meticulous technique and prophylaxis antibiotics minimize the incidence of infection, but it still occurs and must be treated energetically, with removal of the implants if necessary. Skin breakdown. Surgical exposure of the fracture involves cutting and immobilizing the skin, which may not heal. The implants are often bulky, and this can make skin closure difficult, especially if the soft tissue sealing. If the wound breaks down, exposing both the implant and the fracture, an infection affected non-union is likely. The complication can lead to amputation. Neurological and vascular damage. In some fractures, exposure to the fracture may involve mobilizing or retracting nerves and vessels. The swelling and bleeding of the fracture makes this difficult to identify and vulnerable to injury at the same time of operation. Fracture healing. When a bone is fractured, it heals with bone. Bone is the only solid tissue in the body that can replace itself in this way. The rest heal with fibrous tissue that leaves a scar. Bone healing is simple when it occurs smoothly, complicated when it does not. In ideal circumstances, the hematoma that forms around the bone ends coagulates, the clot is invaded by cells, which form a hard mass or callus that resembles cartilage, and the callus is gradually converted to the bone. Fortunately, hematoma in other situations do not normally become converted to bone, the process being initiated by stimuli from the bone itself. The stimuli are to be found in the bone marrow, surrounding osteoblasts, and the periosteum, but their existence naturally is not known. Sound bone healing does not always occur in the bone and ends are then either joined by a motte of fibrous tissue or a false joint, pseudarthrosis, neither of which is mechanically satisfactory. Fractures through cancellous bone with a good blood supply surrounded by muscle and without associated soft tissue trauma have an excellent chance of healing, whatever is done to them. But fractures at the middle of the shaft of long bones, particularly with extensive soft tissue damage, have a high incidence of non-union. Bone gradually gains in strength and the bone is united when it's strong enough for normal use. This is a variable criterion because a weight-bearing lower limb bone carries more load than a non-weight-bearing upper limb bone and therefore takes longer to unite. Even though the rate of healing and the strength of the bone may be the same. Stages of bone healing. First, for the first 2 weeks, bone healing follows the same pattern as the healing of skin or any other wound. This site of wound is filled with blood and broken ends of the bone become necrotic. Second, the blood clot is invaded by macrophages and osteoclasts, which remove dead bone, and osteoblasts, which produce bone instead of the fibroblasts, which form fibrous tissue and soft tissue injuries. Third, between 2 and 6 weeks after injury, osteoid tissue develops and forms a firm mass or callus around the fracture, and the desiccation of the osteoid begins. Callus forms both outside the bone as subperiosteal callus and inside and the endosteal callus. The pH of the tissues increases at this stage and calcium is deposited. 4. Between 6 and 12 weeks, ossification occurs as solid bone bridge crosses the gap and the bone regains some mechanical strength. 5. Between 12 and 26 weeks, the callus matures. 6. Between 6 and 12 months, the gaps between the cortical ends are bridged. 7. Between 1 and 2 years, remodeling occurs, bone prominence becomes smooth, and normal bone architecture is restored. The time is very variable and is much faster in children, in whom callus can be seen at 2 weeks. Malunion. The term malunion is applied to a bone which has unit soundly but in the wrong position. This sounds alarming but does not always matter greatly. Fractures of the clavicle almost always unite with little shortening and overlap, which is quite acceptable and does not affect the functional result, but in the fracture, where the fragments are pulled apart by the unopposite action of different muscle groups. The functional result of malunion is poor. Cross-union. Cross-union in which two adjacent bones become linked by a new bone is a variety of malunion. Cross-union is a forearm block pronation and supination. Non-union. If the healing process fails, the bones do not unite and remain separate, this is a serious problem in a weight-bearing bone but may cause less disability in other alterations such as a fractured metacarpal. Two types of non-union are seen. First, hypertrophic, and second, atrophic. Hypertrophic non-union is characterized by a massive calf of bone around the ends of the fracture that looks a little like an elephant foot. This fracture are trying desperately to heal and can be helped to do so by rigid internal fixation. Atrophic non-union shows rounding of the bone ends, sometimes so marked that the tips of the bone ends resemble pencils, and the medullary cavity may be closed. Pseudarthrosis forms in some patients if there is no sign of osteogenesis. Treatment must aim to kickstart this by bone grafting with fresh cancelled bone or marrow. Delayed union. Fracture with a delayed union takes longer to unite than a normal, but eventually does so. It is important to distinguish delayed union from non-union because non-union requires separation, while delayed union simply requires patience and careful observation. Separation of the two types can be difficult unless there are positive signs of non-union, such as closing of the medullary cavity of the fragments, which makes the diagnosis easy, or an improvement between one radiograph and the next. The diagnosis rests on comparing the rate of bone union with the normal rate of healing of a fracture in the same situation. That's all. Thank you.